Mhm.
Hello, we are Team 3, and we're presenting on preventing scar tissue growth with an implantable hydrogel.
So arthrofibrosis, which is also referred to as frozen shoulder, stiff knee, stiff elbow, and adhesive capsulitis, is a disorder that occurs after repeated injury or surgery and is characterized by excessive collagen production and adhesions. Hypertrophic scar tissue, which causes scars to be thicker and raised, has been found to have a higher amount of microvessels than normal dermis, which suggests that the angiogenic response is overexpressed in these areas. 3 to 4% of patients that receive a total knee arthroplasty develop arthrofibrosis and experience chronic pain and a poor recovery of their range of motion due to this disorder. Our clients are any people who will be undergoing an invasive surgery due to which scar formation is a risk. The scar on the left is chronically inflamed and formed around implanted biomaterial. Cases like this can necessitate a revision surgery. The knee on the bottom here has a buildup of collagen from scar tissue, which causes arthrofibrosis and pain in the joints. Besides making more strategic incisions, current technology focuses more on reduction after scar tissue is already formed, putting patients at risk. Our lab has the technology to limit the growth of scar tissue and this issue. Our audience includes surgeons, patients, and insurance companies. Surgeons would be interested in an innovative device that will improve patient outcomes and prevent the need for risky revision surgeries to remove the scar tissue. Patients will also be benefiting from only needing a single surgery, as this will lower the risk of complications, including those that affect range of motion. In 2010, 4.7 million people underwent total knee arthroplasties, a figure which is expected to continue climbing. The elimination of these surgeries would appeal greatly to insurance companies who also help to pay for them.
4 popular current treatment methods are pressure and physical therapy, corticosteroid injections, manipulation under anesthetic, and revision surgery. Physical therapy and pressure therapy are more preventative measures, but often scar tissue forms regardless and becomes very painful. It can largely limit one's range of motion. Corticosteroid shots can be helpful in reducing pain, but doesn't reduce the fibrotic tissue buildup, meaning that they can't help with the range of motion problems. Manipulation under anesthetic is when the patient goes under anesthetic and the surgeon flexes the joints to initiate movement against gravity. This is a couple $1,000s and there's no promise of it working. And finally, there's revision surgery, which is done when there's too much pain or range of motion problems. The additional surgical work will be attempted to help remove the extensive scar tissue formation. But of course, this is risky as more surgery can lead to inflammatory responses and rescarring of the area. The reasons there's so many current treatments for scar tissue is because none of these options are 100% effective in relieving pain or increasing one's limited range of motion, and most of them have a chance for recurrence. So our device will limit the formation of scar tissue growth in the first place, working to prevent these risks. Since none of these treatments are 100% effective, there are more innovative treatments that have been researched in order to help limit scar tissue formation. One of these treatments being worked at Boston University are injections of relaxin 2 in shoulders to alleviate arthrofibrosis 8 weeks post-surgery. Relaxin 2 is a hormone that is upregulated during pregnancy that has antifibrotic effects, which can lead to fibronectin degradation and can reduce collagen production. While this treatment method does need a lot more testing, it does look promising in aiding with the pain and range of motion in stiff shoulders. But our method aims to eliminate the formation of scar tissue in the first place to mitigate the need for post-op treatments like this one. Another hydrogel for aiding with scar tissue formation are adhesion barrier hydrogels being worked on at Stanford, who are using hydrogels to limit the formation of fibrous bands of scar tissue between internal organs. Scar tissue between internal organs can be dangerous as it can impact the function of the organs, but our product looks more at preventing scar tissue for joint pain and range of motion issues, as these are more common. The other flaw with this product is that even though their animal trials have been showing positive results, the product degrades in 2 weeks. But there are cases where scar tissue can form later than 2 weeks. So we believe that the degradation rate is a little too fast, which we hope to address with our product.
So our approach is to create a way to allow electrical stimulation to be delivered to an area of expected scar tissue growth without permanent implantation. STIM has been shown to promote healing, and although there are many known beneficial applications for this technology, it has not been studied for use with scar tissue. We believe STIM will help with the healing process in instances where scar tissue is likely to form by promoting the migration of epithelial cells, macrophages, and neutrophils, as well as increasing blood flow. In addition to this treatment, we also wanted to stop the formation of scar tissue at the source by limiting inflammation and angiogenesis. In order to allow STIM to be delivered deep enough into the affected scar tissue while also limiting the formation of scar tissue, we will work to create an electroconductive hydrogel. If a surgery is likely to result in the formation of scar tissue, the gel will be placed under the skin before the patient is closed up. This, coupled with an external electrical stimulation device, will allow current stimulation to be delivered deeper into the tissue than typical non-invasive stim. The gel will act as an amplifier to the electrical stimulation, promoting healing deeper in the affected tissue. Meanwhile, the other components of the gel that I'll be getting into later will be working as anti-angiogenesis therapy and limiting the deposit of collagen to stop the growth of scar tissue. Our goal is to minimize scar tissue growth by 80% by volume, meaning the exact amount will vary by patient and application. And patients will pay for this treatment as part of their surgery, as a thin layer of the gel will be spread on the entire affected area before closing. So now we'll get into the components of the hydrogel itself. The hydrogel will be created by using photopolymerization with the usinic acid and TSG6 protein added using passive absorption. A conductive choline-based ionic liquid called BioIL is a biodegradable alternative to other conductive hydrogel components like metals in the form of nanomaterials. This, with a polymer base of PEGDA chosen for its hydrolytic stability and a 20 to 80 ratio of polymer to BioIL, will give the hydrogel its structure. And this ratio was chosen to maximize conductivity, which is shown in the graph on the right. As mentioned earlier, the UA and TSG6 will be added through passive absorption, and usinic acid was chosen for its ability to suppress VEGFR2 signaling pathways, which will lead to the inhibition of angiogenesis, and TSG6 was chosen for its ability to suppress inflammation and limit angiogenesis. This hydrogel will be conductive, biodegradable, and non-cytotoxic with a minimal inflammatory response, degrading in about 30 days. So now to get into the specifics. TSG is a naturally produced protein and mediator of inflammation. Its main function in inflammation is to modulate the adhesion of neutrophils to the endothelium, which is the first step in diapedesis. Usinic acid is commonly used in products such as deodorants, creams, and cosmetics. It's a product of lichens and works by not only increasing the effectiveness of anti-inflammatory mediators and cytokines, but also by suppressing the expression of various genes responsible for the onset of the acute inflammation phase. By including these components in our hydrogel, we'll be ensuring faster healing through quicker inhibition of diapedesis and will reduce angiogenesis associated with hypertrophic scarring through upregulation of anti-inflammatory factors.
There are several benefits to our device as compared to our competitors. Currently, this is the only solution on the market that aims to prevent scar tissue formation as opposed to treating it after formation. This eliminates the need for revision surgery and allows for increased range of motion for a patient, a metric that's often measured to ensure complete recovery. Finally, there is the added cosmetic value of a non-hypertrophic scar and the quality of life value of a less painful recovery overall. When considering the constraints of our device, there are a few areas of concern. Most notably would be the experimentation we would have to do to get the project up and running. Currently, there are no experimental procedures or related literature that describes the degradation time of our specific hydrogel. And several related gels appear to last only about a month, which is a shorter time frame than what we intend to have our product in the body for. Additionally, these molecules and proteins would be fairly new to the market and entirely new to the medical device scene, meaning that it may be difficult to get it approved by the FDA without significant time spent on testing. There is also an additional cost to each patient that chooses to use this device, which can be seen outlined on the slide under the breakdown. However, it is important to note that this total cost is far less than current treatments, such as a $300 cortisone shot that requires multiple injections or pay-per-visit therapies. Finally, it is an additional step to an already complex surgical procedure and may cause hiccups for surgeons and doctors who have to learn how to inject and monitor the device.
Now for our engineering criteria. First, for our biomechanical standards is the degradation rate of our hydrogel. During the second stage of wound healing, which is around 2 to 4 weeks, is when the fibrin is replaced with a matrix of collagen fibers, and immediately after this is the third phase of wound healing, when the fibers begin to harden and scar tissue gains the definitive elastic and textural properties. Like stated, we believe our hydrogel would degrade in about 4 or so weeks. So prior to it degrading, during the second stage of wound healing, the stim will help the healing process by promoting the migration of epithelial cells, macrophages, and neutrophils, while the other components of our gels will limit the deposit of collagen during this phase, thus limiting the formation of scar tissue, and then the hydrogel can degrade. Another biomechanical property of our hydrogel are the mechanical properties such as tensile and compressive strength to ensure that our product can provide mechanical support to cells and tissues. Based on our research, the BioIL to polymer ratio we have chosen, which is 80 to 20, can have a compressive modulus range from 1.27 to 178 kilopascals, which can vary based on the specific concentrations of the polymers. It can have an elastic modulus range from 2.4 to 125 kilopascals and an ultimate stress of about from 2 to 515 kilopascals as well. All this means that our hydrogel mixture can have a wide range of properties that can be adjusted by changing the concentrations of the PEG-DA if needed, so based on our animal trials. But this base hydrogel has been implemented under the skin before and has been successful without interfering with the mechanical properties of the skin. The hydrogel will also be shear thinning in order to avoid impeding mobility and allowing it to spread under the skin without bulging. Lastly, the conductivity of our hydrogel is about 1,262 times 10 to the negative fifth Siemens per meter, which will allow for the external electrical stimulation to travel through the skin and our gel, deliver current deeper into the muscles for healing, like described earlier. As for biocompatibility, our hydrogel is biodegradable, and due to the organic nature of the bio-IL, the degradation will not result in the generation of any cytotoxic byproducts, and studies show that it does not elicit any inflammatory response in vivo. Finally, the biofunctionality standards of our device is that it will limit the growth of scar tissue by suppressing inflammation and preventing angiogenesis, which can be done by the usinic acid and the TSG6 protein. Lastly, our hydrogel will conduct electrical stimulation for healing by using an external stim device.
For safety and efficacy testing, all tests will be conducted at 37 degrees Celsius to better mimic an in vivo environment and will be following ISO standards. Our in vivo cytotoxicity test will use a direct contact assay, which will test biocompatibility and cellular toxicity. Mammalian cells will be cultured in flasks to near competency, and then a fluid of test chemicals is added to the culture media. These cells will then be observed for signs of toxicity, which may include changes in size or conformation. Hemocompatibility testing will involve thrombogenicity testing, where the materials will be placed in a simulated clinical setting, which is reflective of the direct blood contact levels and examined with a light microscope once removed to determine the amount of thrombus that is formed. Our sensitization test will be based on a local lymph node assay test via an aqueous solution. This is conducted sort of like an allergy test in which the test chemicals are first applied topically and then injected beneath the skin of an animal model, usually a mouse or rabbit, and observed for any signs of irritation. These results are compared to control solutions, usually including saline solution and vegetable oil, to compare both water and fat-soluble substances. Once these tests have passed, implantation testing can begin. Any materials of unknown reactivity will be implanted in rabbit models, usually in muscles on their back, and then compared with known non-reactive materials to determine safety. Multiple tests that examine different points along the expected degradation period will be performed to prove safety and efficacy throughout the entire working life of the device. These tests will be performed in animal models. Our small animal model will be a rabbit due to the similarity in structure to human skin. Rabbit ear models have been used to model hypertrophic scarring, which presents much like a hypertrophic scar in humans. The limitation would be their skin being more fragile and not having the same magnitude of barrier function. Rabbits were selected over rats because their skin is different structure than human skin, particularly in the way that rat hair follicles grow, as the absence of hair is a key characteristic in scarring. Our large animal model would be a pig, specifically a Duroc pig, as the process for healing deep wounds is sufficiently similar to the wound healing process in humans. They are being used as models, increasing frequency to study hypertrophic scarring treatments. When testing the efficacy of our device, we will then need to test the conductivity of the hydrogel, which will be done using a semiconductor parameter, with the probes being placed directly into the hydrogel to obtain a reading. The degradation of the hydrogel will be observed from start to finish in animal models to determine the experimental time frame. To prove the efficacy of TSG6 and UA in suppressing inflammation and limiting angiogenesis, as well as electrical stimulation to promote the internal wound healing, we will be using rabbit models that are exposed to scar tissue formation. In previous studies with HUVEC cells, UA is found to affect cell viability and angiogenesis in a strictly concentration-based manner. This means we'll have to experiment with dosages that promote rather than inhibit healing, while also keeping the gel conductive. TSG6 is a protein that will help us offset the effects on cell viability that UA creates. So determining an ideal ratio of the UA to the TSG6 to the bio-IL will be critical to the success of the device.
Thank you for listening, and we'll now show you our references. Thank you.